So this patient received R-CVP chemotherapy, had a partial response to treatment, and then went on to receive maintenance rituximab. The maintenance rituximab is given every 8 weeks for up to 2 years. And in this case of the patient, we're able to convert the patient from a partial response to a complete response during maintenance therapy. Maintenance therapy with rituximab has changed progression-free survival in patients with follicular lymphoma. Indeed, from the PRIMA study, which was the first to explore maintenance against observation in the frontline setting, demonstrated a significant improvement in progression-free survival. And indeed, with long follow-up, just over 50% of patients have remained progression-free for those who received maintenance in the PRIMA study, some 10 years later. So it's really changed the clinical course of the disease. So in the Gallium study, maintenance therapy was used as well, given for a total of 2 years, and no doubt contributed to the efficacy of the third generation antibody. There are concerns, however, with using maintenance therapy. The concerns are toxicity. So we do see an increased risk of infection, and that's because we see chronic depletion of B cells, and so there are risks of infection. I think it's really important that patients are vigilant, that they report infections early, and then we get on top of these rapidly. Often these are infections of the sinuses or the kind of upper respiratory tract, but we do see some rarer infections as well. And occasionally we see patients who have modest degrees of neutropenia during maintenance therapy. So we must be vigilant with our patients whilst receiving maintenance therapy. So prophylaxis for patients with high-risk follicular lymphoma. First of all, the question of do we require prophylaxis for tumor lysis syndrome? The risk of tumor lysis syndrome is modest in patients with follicular lymphoma, and I use allopurinol prophylaxis during the first cycle, but it doesn't require anything beyond that, obviously having checked the urate level before we started. I think it's really important for us to consider antibiotic and anti-infective prophylaxis in patients receiving frontline therapy for follicular lymphoma, and particularly for those patients who are receiving bendamustine therapy. We know that bendamustine therapy, given in combination with an anti-CD20, is a kind of highly immunosuppressive regimen. And indeed, from the Gallium study, what we did find was that patients receiving bendamustine had a chronic degree of T cell depletion, particularly CD4 T cells, that extended beyond the time of induction and maintenance treatment and went into the follow-up period. So for patients who receive bendamustine therapy, because of the risk of the T cell depletion that comes with the use of bendamustine, I give these patients prophylaxis against zoster reactivation with acyclovir, but I also give the PJP prophylaxis, and we use whatever is of our institution's recommendations. And I continue that during the maintenance period. And I think that was something that was really important that we had learned from the Gallium study about the long-term degree of immunosuppression associated with the use of bendamustine. When I talk to patients about what's important to them in the management of their follicular lymphoma, is actually being free of the disease for as long as they possibly can be. And this comes out also in quality of life assessments for patients with follicular lymphoma. Using obinutuzumab rather than rituximab is associated with prolongation of progression-free survival. And what that means is that patients enjoy a longer remission and have a greater chance of staying in a longer remission because they have a greater chance of being PET negative at the end of induction. They have a greater chance of MRD negativity at the end of induction. And if we can use treatment regimens that are associated with prolonged progression-free survival, then we owe that to our patients. And so for that reason, I use obinutuzumab for our patients.